problem. So long-term implications to health and development are going to occur. Let's start off with a small quiz. You write down your answers and then we'll discuss why I'm right and you're wrong, okay? So on that first one, at birth, the brain is fully developed. And just like the heart and stomach. So you just jot down so that other people won't know that they got the answer right and you didn't, etc. So think about it. At birth, the brain is fully developed. I'm not talking about the size of it, that comes with growth, but developed. Everything that's supposed to be there is essentially there. The second one, the brain's development depends entirely on the genes with which you were born. Some of us are very natural geniuses and others have to work at it. So true or false? Okay, a toddler's brain is less active than the brain of a college student. I like this one. And then the last one, with children need special help and specific educational toys to develop their brain power. All right? Simple questions, no problem with that. You know the answer. Now let's see about that. Here are your facts, whether they're true or false. That brain at birth is developed. All the neurons are there. All the neurons you're ever going to have are there. But it's the pathways that are not developed. The synaptic pathways. So you're born with all the brain power that there is. It's putting those connections there that go into the development of the brain itself. Most of the connections are made during actually infancy and childhood. So to get that brain fully functional, that requires making sure that child stays as engaged with their environment and everything else as possible. And that's what's going to start those synaptic synapses connecting, okay? So we are born with all the brain we're ever going to have, but now it's developing the connections. And it's the connections that make us just mere mortals or Einsteins. Okay, for the second one, development is entirely on the genes that you're born with. No, early experiences are what's going to go ahead and cause interaction with the development, and it influences the way in which those circuits or pathways are going to be developed. So stimulation is necessary. They need to interact with their environment. They used to teach in psychology way back when, and probably still do because the problem is still in the books, etc., that children that are not introduced, not interacted with, not allowed to get outside of just their crib, their small area and all, develop, which I can't remember the name of the disease, it starts with an M now, will die. They wither away and basically die from the lack of interaction. Now, I can't imagine what kind of, how that research was run, but if it was back in my day, it was in the book, it was there, it was done. But children without being able to become involved in their environment do not survive, or do not survive very long. You can feed them, give them oxygen, but if you don't interact and help that brain connection, they're not going to make it in the world at all. So, it has nothing to do with genes, it has to do with the interaction. Okay, the third one, which is false also. By the age of 2, the brain is 80% of its adult size. Which makes kind of sense when you think about how we're growing anyway. Everything else is growing, so why wouldn't the brain also increase in general size based on connections going on? By 3, the brain has what they say is, I can figure it out how they can figure it out, 1,000 trillion connections. So by 3, they are really connecting, particularly if they're out there exploring their world that they're in. And those connections are actually twice what the adults have. So by 3, these kids have a lot of potential. If it is not exercised, not utilized, stimulated, it goes away, it disappears, it becomes disconnected. And with that disconnection, their brain is no more connected than that of an adult. So it speaks to getting in there and doing things with these children. Even if they're, and talk about, and you've heard it in the news, different things, children with severe disabilities, handicaps, what do? They take them all the way back and start them crawling again, interacting, etc., to rebuild connections and to help them develop more. So 1,000 trillion, twice as many as adults have, which means we've been wasting our brain along the way. So there's a lot more that's there. A baby's brain is super dense. There's a lot that's there. Of course, it hasn't expanded, and so it's really pushed together and all. And it'll stay that way for about the first decade of life. So we have 10 good years to take a child that may have a problem or develop a problem to go ahead and work with them so that they can develop what's going on and then continue on into what we call normal itself. So that's a lot of potential that's there and should be utilized and is utilized. By 11, it says that if it's not used, the brain starts to get rid of the connections. It starts pruning itself, in other words. So up to 11, because it doesn't want to have all these wires that are not doing anything. So the brain literally prunes itself and starts seeing things disappear. We see pictures of the MRIs, etc. It shows very dense in the beginning, then as time moves on, you can see that it's looking less dense. Less utilization, less is going to be there for them itself. Now what remains is still powerful in itself and efficient, but greater potential is actually lost. So less active than the greater loss. And the last one, child needs special help and specific educational things. Because I know that great toy manufacturers really don't like that one. They don't need all these special things going out there. And it makes it look, the little Einsteins, a little this, a little that. They don't need that. They just need to have that interaction with their environment. You going along each day and saying, you learned about the letter A yesterday, today's the letter B. That will work just as well as buying every CD out there, every book out there, every, what I like are the little computers. Kids can't tie their shoes, but they can sure get on the computer and call war, Star Wars. So they just need the interaction, new experience, loving care, something that makes them want to learn because it makes mom and dad happy, makes the teacher smile, etc. I have family that teach elementary, they don't smile anymore. They talk about kids and they say, but what happened to their brain? I try not to take them down my scientific route according to literature and all, because they're not into that. I'm STEM, they're not. But they wonder what's going on, that the kids, it's so difficult for them to learn, or they're not interested, they're not amused. So, loving care and new experiences, all of those things are helping with brain development. All right, so with that wonderful beginning, let's look at the oral assessment. And what are you looking for? What's going on? The areas. First of all is that level of consciousness. There's a lot of things going on, but you want to be sure that you are placing in your brain, as you're doing your assessment, under what does it fall? Okay, what is the level of consciousness? And I do remember teaching this last semester too. Level of consciousness, anyone? How many levels are there?
5.
Can be up to 5. Some literature keeps it at 4. What's the highest level of consciousness? Awake and alert. Thank you very much. So, does it require any stimulation or anything you need to do to determine that level of consciousness? How do you know that they're awake and alert? Ask. You walk into the room, they notice a change in their environment. You don't have to say a word. You don't have to clomp in and make noise. It's just that somewhere they pick up that there's been some kind of change in their environment and they turn toward it. Or they acknowledge there's been a change. It doesn't mean that they know who you are or anything else. You may walk in and they'll look at you and say, oh, Uncle John here. Well, no, not today. No, we're not looking at the intellect. We're looking strictly at, is the nervous system up and alert to what's going on in its environment. So the highest one then is awake and alert. If you're not awake and alert, what's next? What's the next lower one? Lethargic over. Basically, you're looking at, it requires some stimulation. Lethargic, think of yourself, this afternoon after lunch sitting in a class. It requires a little stimulation to bring your head up and go, oh yeah, where am I, what's going on? And that. So it's less spontaneous. It requires now some input into the central nervous system, one way or the other, in order to do that. And when we have that occur, it's never a good thing. Extreme irritability or lethargy is not, is considered a really abnormal finding in a child from infancy up. We don't expect to find them at any age, etc., to be lethargic. When they're stimulated, yeah, they're asleep, that's one thing, etc., but it's not considered a positive bit of information picking it up. Now, you also have to keep in consideration, let me go to the next one. After lethargy, what comes next? No.
Observation.
Uptunded? Uptunded. Uptunded. Sometimes you'll see it interchanged with the stupors and all, but uptunded, which means it requires more stimulation to bring them up to a higher level of consciousness itself. So just like we were taught in CPR, where they put two things in there. You have someone just sprawled out on their, just a look saying, Mr. Jones, are you okay? Mr. Jones, Mr. Jones. So you have to now add more of a physical, not just the words, but it now requires more stimulation to bring them up to a higher level. Doesn't mean you'll take them up to alert, awake. You may get them up to lethargic. That's fine. One of the things you have to be careful though with children, young children in particular, they respond to something they already know. As a stranger going into them, calling their name, they may not respond. You're unfamiliar. And safety says keep the eyes closed and don't act like you heard anything. So they're not responding to me. Mom, call his name, call her name. And oh, baby, and they, oh, hi, Mom, it's you, okay, say that. So keep that in mind. They're not responding because it's not familiar to them, and if it's not familiar to them, they're afraid of it and are going to lay low. And then, uptunded, after that comes okay, we'll work on coma now. There's no such thing as a semi-coma. That's a vegetative state, and it actually falls under coma itself. So the comatose, where there is no response or not a positive response to stimulation. So you've had that. You've had neuro already in MedSurg 1?
No.
Today? Oh, lucky. The movement. This is where it gets so confusing for family members and friends. Oh, look, they moved. Yeah, but their movement was so wrong, so non-purposeful, so dangerous itself. So with coma, it's either complete, nothing's going on, or there might be a type of reflective activity which is non-purposeful. The body always wants to protect itself with a purposeful movement. These movements are non-purposeful. Cerebral and decorticate type of movements. All right, so that's the first one we look at. We hit that coming through the door. So we don't go in and talk about Glasgow Coma Scale. We use that for trauma and different things. People will write Glasgow Coma Scale. It has nothing to do with anything. You're looking just at the level of consciousness and how you're picking up things. Glasgow Coma Scale comes with a more involved type of injury and higher level of assessment. Okay, vital signs, always, as to what's going on, because they may provide a probable underlying cause for why there has been a change in their level of consciousness itself. And we're always thinking in terms of oxygenation and circulation. So if the vital signs are changing, how's the breathing going? You know, what's the heart up to? Are they circulating? What's perfusion? You're looking at that. Okay, head, face, neck. You're looking at it. Certainly in infants, what we're looking at are those suture lines. We've got our hands all over their head. We're feeling for those soft spots. What are the fontanelles doing? Are they still soft? Are they now tense? Which shows that there's pressure underneath, increased intracranial pressure. At their age, the sutures shouldn't be closed, but the sutures are closed. That's really problematic. So we're looking at checking out the head for everything that's associated with it. We're looking for any asymmetry of the head and the face, because there's maybe cranial nerve involvement, or still some bone structure that changed in how the head is growing, and the bones are fusing or not fusing for these children. So looking for asymmetry, which may show that there's some paralysis or some cranial nerve damage that has occurred. And you'll get that a lot more in OB, some of the things that are seen for them. We may see something initially in some of the newborns, and it may be due to the fact of the position of the uterus, and it disappears in a couple of hours. But we need to check head, face, what's going on with the neck. Okay, your cranial nerve functions. Everyone likes to whip out their little flashlight and take on the eyeballs, the pupils itself, which is nice. There's a number of other things we look at in the eye. When we're looking at the eyes, we always look to see if it has what's known as nystagmus in the book. Do we see the eyeball oscillating either back and forth or up and down? That is not normal. It's known as nystagmus. So we're looking at their eyes, not just the pupils, but what are the globe of the eye actually doing, the movement itself going on. We also look at the position of the eye in the head and in its socket. They look like they're constantly looking up. Do they have that half look, or what we call the sunset or sunrise eye, where it's either halfway down, you only see half the iris, either the top half or the lower half? Not a good sign. It's usually associated with increased intracranial pressure, so we're also looking for the position of the eye within the socket itself, which also goes back to some other problems going on. Motor function. We see them resting, just laying there looking just as cute as they want to. How are they resting? What is the position that they rest in? Yeah, we put them on the back, but when we're looking at them, there are certain, how do they look when they're resting? You put them down and they're just sprawled all over the place and all. They look something like a rag doll. That speaks to another problem. Why are they so hypotonic? Why do I not see that muscle tone that's there? Because all babies have plenty of muscle tone, etc., unless they have certain genetic problems. We'll talk a little bit about that. Down syndrome, they're very hypotonic babies, etc. So we're looking at that motor function itself, and they lie quiet. We don't see it twitching normally, not at all, etc. So we're looking for resting. What are their reflexes? Their primitive reflexes. What reflexes did Dr. John go over with you when she talked about? Yeah, she did that with initial growth and development, I believe. Like Moreau. What's the Moreau reflex? I think that was on your last test. Moreau, the startle reflex? Yeah. Yes, you're demonstrating it correctly up there. Right, that's a very primary one that we're looking, that should be there. The first 3-4 months, going on. You know, is it still there when they are 9 months old? Do they still have a startle reflex? I hope not. The grasp reflex, the minute, and this is what gets the heart of everyone, when you're in with a newborn and like lean down and you put your little finger there and the kid grabs it. The grasp reflex. Oh, they love me, they want me to stay with them, etc. Very normal, but you put your finger there and the kid's like, no, I don't think so, not today. Something is wrong. The Babinski, I know I mentioned it, the Palmer reflex is different in a infant, not Palmer, plantar reflex. Adults don't have it. The Babinski we have, but it's the opposite of what we see in a child. So looking at those particular, okay, with the plantar reflex, that's the foot. So you got the little cute foot there, and you hit it right in the, I'm gonna say the plantar area, it's the top part. When you touch it, the toes curl down. They lose that about, or they're a year, they lose about 6 months of disappear. But you hit it and it curls down. Babinski, when you do it in the adult, remember, you're not going into the center. You come around up to it. In an infant, they extend the fingers, they extend the toes. So if you come around, this is normal for them. You do this to an adult and they do this is abnormal in an adult. So this changes to the adult phase of curling down when they're about a year old. So we're looking at the reflexes. Are they making the change to the adult side, either disappearing or becoming what we call normal as far as an adult's concerned? So you're looking at the difference between the two when you're looking at reflex. Okay, the suck reflex certainly is persistent. We expect to see it. They suck in utero. You see a little sucking motion going on, and when they're absent, it's a reflex that is there. It can be lost if they are not given something to suck on as infants. Perhaps this is a child with certain abnormalities, and they're completely NPO. We don't not put anything in their mouth to eat. They will lose it. Now, for those children, we actually have to teach them how to suck on a bottle as time moves on to redevelop it so that they can eat. But we have to look at, is it associated with eating, feeding? Even when they put the food in a tube for an infant, they'll put a pacifier or something in their mouth so they'll suck it and associate it. Movement of the mouth, yummy in the tummy. Okay, so you're looking at all of those things. Also, when we're looking at the normal reflex going on. Now, I'm going to talk about sucking away the column. You see a young infant just sucking away, and there's nothing in their mouth. That's a seizure. So, being able to differentiate based on the scenario or what's going around will tell you if this is normal or abnormal. So, call it behavioral, looking for behavioral clues as to what's going on. And then the increase in cranial pressure. Pick that up. Certainly, your infant whose fontanelles haven't closed yet, when you touch them, they're just as firm, tense. There's something developing in there. The fluid, it's not the brain suddenly growing, etc. Something's going on. The mass and volume within the head is changing and it's pushing against the soft spots. Once the fontanelles have closed, then we have to look for a few other signs and symptoms that there is something that is increasing pressure inside the head that's having a negative effect on everything related to neuron. And that's when we see what's going on with the eyes and a few other things. So, bottom line, you need to know what's normal. And if you see something that you think is normal, but it's in the wrong situation, then it's abnormal. Make sense? Okay, increase intracranial pressure. This may occur in a lot of neural disorders, you see, itself. And so there's a number of things we spend time looking at it, as to what's going on. Headache, just like, infants can't tell you they have a headache, they'll show you how irritable they are, or how quiet they suddenly get because it's so uncomfortable, they don't know what else to do with it. So we ask, certainly an older child can tell you that early signs of increase in cranial pressure, said how often does it happen? More than one would normally think of. So, may have been a headache, a mild headache, it may be seizure activity, itself. And that's the first indication that there is something else going on, in the cranium itself. Vomiting? Yeah. Now, projectile vomiting, what else have you heard about that? We'll give you projectile vomiting. Pyloric stenosis. So once again, it's looking at when is this occurring? What is going on? Now the vomit center is located in the brain. So any pressure in the brain that pushes on that particular area, the CTZ area, is going to make you vomit, make them vomit, etc. So if everything is okay with the GI tract, the other concern is what's going on in the head. Decreased pulse and respiration. Why? Why would they decrease? Let's start with the easy side. Why would respirations go down? What controls your breathing? Brain, which part? Medulla and pons. One handles depth, the other one handles rate, etc. So, but it is the primitive part. Yeah, the primitive part of the brain. So they're slowing down. Remember, it was said before, one or two of us, children will have a respiratory arrest, not a cardiac arrest. They're far more prone to not stop breathing. And when you're looking at infants, do they breathe nice and normal and regular? No, because that part of the brain is still trying to figure out what is nice and normal and regular. It's immature. So if something goes wrong, the first thing is, that's part of the brain says, I give up. So we're looking at that. Pulse. The heart rate will go down. Heart rate tends to go down when blood pressure goes up. So the two are, say, increased blood pressure or pulse pressure. The difference between the systolic and the diastolic. They go together. Pupil reaction time. We expect when we check anyone's pupil that the reaction is going to be nice and brisk. And hit it with it and it's going to do this. It's not going to, I'll slowly give this, I'll make up my mind any moment now where I'm going. So we're looking at, is it getting sluggish in its reaction? Or worse yet, is it unequal? One pupil says, yep, and the other pupil says, no, I'm not doing it. It's always a high index of suspicion, something's going on in the head. Okay, the sunset eyes is talking about either you see top half of the iris or the lower half of the iris itself. It's known as sunset. And already talked about that's the infants. Besides the fact, and been told when you go in up to about the age of 6 months, the head is measured also to see how it's growing, which is about ½ an inch per month. So, but are the spot mouths tense? Are the sutures wide when we feel down and it's like there is space between these? What's going on here? Scalp veins. We can see babies' veins in the scalp very easily. When in doubt and we can't hit anything else and they need an IV, we'll use the scalp veins going on. So when we see them dilated and very obvious, we know something's wrong. Something is just plain old-fashioned wrong, and let's do a closer check. And then the high-pitched cry. They have a cry that makes a cat in heat envious. When it says high-pitched, they're about ready to break glass. So anytime we hear that, it's okay. Something is not right. It is a true cry for help. Okay, the leg side, certainly a little consciousness of bradycardia, or mentioned, change notes respiration. People can have just respiration and not be dying, that has nothing to do with it, it's just the irregularity of what's going on. The severed and decortical posturing, where, the rigidity, flexion, it's a worthless movement of the body, it's not protective at all. And then certainly everybody knows about fixed and dilated pupils. So, what are they going to do? What are you going to do in assisting? Anytime a child comes in, particularly an infant, and they're showing signs of irritability, they may have a little bit of fever, not really sure. Pediatricians usually want to go ahead and do a lumbar puncture, get their hands on, see what that CSF is. What does it look like itself? So you're assisting in doing that. So for the infants, we said, it can be upright where we actually sit them up and bend them, and that vertebrae spreads very nicely that they can get into the spot itself. The other kids, those are the ones we'll have lying down on the side, or curling them up, where you actually are going to get them under the back of their legs and help bend them, and have them hold that position. But infants, we sit them up and they droop forward very nicely and do it. So looking at the proper positioning as they go in and retrieve the CSF itself. Certainly head and neck injuries can occur, particularly with infants, since they don't have good control of their head until about what age?
4 months.
4 months to 6 months, some of them a little more developed, some of them so chunky that it holds their head up for them. But other than that, we really have to have good control of the head, and sometimes it doesn't occur in the parent children. So we have to really get an X-ray and see what's going on. They're so vulnerable, with head injuries and all. So if someone really doesn't know how to handle a child, yes, a head injury is incidental, but unfortunately most of the time it's not incidental or accidental. So getting that head and neck X-ray is one of the things commonly done. CT scan, see what's going on in various parts, etc. And the electroencephalogram can happen where they're going to do it in some of the older children. Some of you have already been up on the, was it the 10th floor that has, it's neural? Yeah. I remember where back in there, the seizure area where they actually try to provoke a seizure in the child so that they can pick up on where is it, and who was it that said yes? There. Were you there that day? Oh, no, you're not with me.
That was me.
You were with me.
Me.
Okay. Yeah, you're all over the place. Yes. When all of a sudden the alarm bell went off, it was like a code, everybody that way. Because they have been trying to provoke a seizure anyway, because that's how they can tell meds working, not working, what part of the brain is actually affected. And the child was hooked up to 14 different things going on, so they can see what is going on. And you'll see that also in some of the adult units also. So it is very diagnostic. Okay. Alrighty. One of the things that greatest concern with infants is they have no immune system, period, for a period of time. And they're prone to anything. So coming down with a bacterial infection or a viral infection, either one, are they coming down with meningitis, inflammation of the meninges. You know that the meninges protects the neural system from invasion of anything, normally. But not in kids, not the young children, etc. It's about everything can get through, etc. So they're always wanting to check for meningitis, which could be bacterial, viral, or aseptic meningitis. So there is aseptic, there isn't any organism that's there. It's just that it is basically a chemical type of irritation that will occur. All of you along the way have probably had the aseptic meningitis. Have you ever bumped your head and had stars and a sore neck somewhere along that? You said, oh, I hit my head. You didn't injure your neck. Our muscles are too strong for that. What you did was cause a small bleed, and the body does not like blood outside of blood vessels. You had an aseptic meningitis. So, Just keep it that way, don't go into the other two, they're so messy. So they're always having to see that, and what could be more upsetting to the head than being born? You know, molding that's going down and everything else. So, along the way, but they have to check. If it's bacterial, they do their lumbar puncture, they get the CSF, just looking at it can tell whether it's viral or bacterial. If it's cloudy, it's bacterial. If it's clear, I'm not really sure what's going on until they take it to the lab itself. But they're gonna put them on antibiotics, get it into them one way or the other. So by mouth, IV, or intracatheter, which means they actually put it directly into the spinal channel itself. Anticonvulsants, it is not unusual that with meningitis that a seizure may occur. It doesn't mean that they're epileptic, just like a seizure that goes with the febrile seizures. It's not how high the temperature is, it's how fast it gets there that causes the seizure. So if someone has a high temperature, we give them medications, temp may go up, but it goes up slowly, and they're less likely to have the seizure. If it's allowed to race up there, they are going to seize, okay? So it's not how high the temp, it's how fast it gets there. So we have to work quickly work quickly to slow it down. Okay, benzodiazepines, everyone's favorite, still used out there, so commonly, any way we can get a little Valium on board, works nicely, the more common one. Certainly there's plenty of others. Analgesic, Tylenol, acetaminophen is drug of choice for better than everything else, but ibuprofen, Advil, Motrin, all of those are there. Morphine is for some other serious reasons going on, but they are used. Your osmotic diuretics, tell me two of them. Mannitol, good. What was that other one?
Polyethylene glycol.
It'll pull fluid down to the GI tract faster than anything else, but it's not really diuretic, but it'll move fluid around through it. Now, Osmotrol or one of the ureas, that can also be used, probably the mannitol is the most popular one. And then steroids. When in doubt, there's always steroids that are used. So these are the common medication classifications itself that are used in neuro, general neuro. The anticonvulsants come under a couple different classes. Okay, when looking at the structure, the neurologic disorders in children have a devastating and lasting impact. It's so many of them, and the categories on which they go. The neural tube defects, okay, the neural tube develops very early in life itself. Those defects actually occur within the 3rd to 4th week of development. So by the time a woman finds out that she's pregnant, the neural tube